Can start? Yes. Hello everyone. I'm Dr. Ujwala, mentor at StudyMEDIC. Welcome to our YouTube series on early pregnancy modules. Here today we are discussing topic Down syndrome screening and abortion clauses. We will be also taking few SBAs and EMQs. So let's get started. I would also like to start with a proverb. Hope is not a dream, but a way of making dreams become reality. Think of it in this way, that dream is like a blueprint, and hope is the engine that would drives you and build it, and that will help you to clear this exam. So let's get started with our topic, Down syndrome screening. The first is PA. Miss Suji is a 41-year-old woman attending for antenatal booking. She conceives spontaneously and has no significant medical or family history. Her previous pregnancy was uncomplicated. A dating scan confirms a singleton pregnancy at 13 plus 4 weeks gestation with no structural abnormalities. She is concerned about her age related risk of Down syndrome and requests non invasive screening. No screening has been performed so far. And the question is, what is the most appropriate screening test to offer at this gestation? The key word is 41 weeks and 13 plus 4 weeks of gestation. So, coming to the option, here the CBS and amniocentesis are the diagnostic tests. Triple, quadruple, and the combined test are the screening tests, out of which triple and quadruple tests are the second trimester screening tests. So, the correct answer is combined test, which include NT, PAP-A, beta SCG, and it is performed between 11 to 13 plus weeks of gestation. Moving forward, a 29-year-old woman, gravida 1 para 0, attends antenatal clinic at 12 plus 2-week gestation for routine care. She has a spontaneous singleton pregnancy and no significant medical or family history. She consents to first trimester combined screening for trisomy 21. Regarding her trimester combined screening for trisomy 21 in this patient, which of the following statements is most correct? So detection rate is 90, 99%, 75%, 65%, and 80%. So the correct answer for the combined test is detection rate is 90% and the false positive rate is 5%. Please go through this chart. Most of the SP are based on this. Here you can see the cell-free fetal DNA is high detection rate of 99%, while the double test is 60 to 65, and for triple and quadruple add 5 in each, and false positive rate of all the screening tests is 5 except cell-free fetal DNA of 0.1%. Moving forward, a 38-year-old woman present at 16 weeks gestation for antenatal booking. She missed her first trimester appointment due to travel. She now requests screening for Down syndrome and prefers a non-invasive test. What is the most appropriate screening test to offer? It is they are talking, asking about the second trimester screening. Again, you can see the options here. CBS and amniocentesis are the diagnostic test. Combined quadruple and nuchal. Out of this, combined test and nuchal translucency we are doing in the first trimester. So correct answer is the quadruple test, which includes alpha fetoprotein, beta SCG, unconjugated estradiol, and inhibin A, and it is performed between 15 to 20 weeks of gestation. Next is BA. A pregnant woman has a previous child affected by Down syndrome. In her current pregnancy, she undergoes non invasive prenatal testing, which returns a high risk result for trisomy 21. She subsequently has an amniocentesis, which shows a normal fetal karyotype. What is the most likely explanation for the discrepancy between NIPT and amniocentesis results? The options are maternal DNA from last pregnancy, placental mosaicism, subchorionic hematoma, or none of the above. The correct answer is placental mosaicism. As an IPT analysis cell-free fetal DNA in maternal blood. This DNA originated predominantly from the placenta, not directly from the fetal tissue. In placenta mosaicism, the placenta contains a mixed normal and aneuploid cell, while the fetus has a normal karyotype. And as a result, an RPT may be positive, reflecting the abnormal placental DNA, and amniocentesis is normal, reflecting the true fetal karyotype. And this is a well recognized cause of the false positive and IPT result. Why the other options are incorrect? In maternal DNA may rarely affect the NIPT, but does not explain the normal amniocentesis in this classic scenario. DNA from the last pregnancy is incorrect because the cell-free fetal DNA is cleared from the maternal circulation within hours to days after delivery. In subchorionic hematoma is incorrect. Why? Because it can increase maternal DNA contamination but does not cause aneuploid specific false positive. And this is the last E is incorrect because placental mosaicism is the established explanation. Moving forward, a 29-year-old woman patient attend antenatal clinic at 12 plus 6 weeks gestation. A first trimester combined screening test reveals that a fetus has a 1 is to 10 chance of being affected by trisomy 21. She would like to discuss further testing. What is the sensitivity of cell-free fetal DNA, non-invasive prenatal testing for trisomy 21 in singleton pregnancy? Options 80%, 85, 90, 95, or 99%. As have just have we have seen, that is the sensitivity of NIPT for trisomy 21 in singleton pregnancy is 99%. Although it is a screening test, confirmation, if it is positive, then confirmation by CVS or amniocentesis is done. Timing at is not performed before 10 weeks due to the low fetal fraction. False positive may occur in multiple pregnancy, IUD, maternal, or the placental mosaicism. The advantage of this test is that it is non-invasive, safe, and no miscarriage risk. But limitation is high cost restrict routine use, typically offered only to high-risk pregnancies. Next is PA, a 37-year-old woman attend the antenatal clinic at 12 plus 5 weeks gestation for first trimester combined screening. This is a spontaneous pregnancy. Her BMI is 24 and she is non-smoker. Ultrasound confirms a single live fetus with CRL appropriate for gestation and an increased nuchal translucency. Her biochemical results are 3 beta HCG 2.6 multiplies of median and PAPA 0.38 multiplies of median. Which chromosome abnormality is most likely? The options are trisomy 30, 18, 21, Turner syndrome, or triploidy. The correct answer is trisomy 21. In Down syndrome, it is characterized by the raised free beta HCG and reduced PAPA in the first trimester. While in trisomy 18 and 13, both beta HCG and PAPA are reduced. Turner syndrome, NT can be increased, but biochemical markers are usually normal or variable. Not the beta HCG raised or PAPA low pattern seen here. In triploidy, usually shows very low PAPA and beta HCG can be variable and pattern does not fit this scenario. Next is a 37-year-old pregnant woman at 14 weeks gestation is referred by her midwife to the consultant clinic following routine Down syndrome screening. A screening result shows NT 1.3 mm, alpha-fetoprotein 1.06 multiplies of median. Both values are within normal range. She is otherwise healthy and this is her first pregnancy. Question is, what is the most appropriate next step in her management? Either amniocentesis, options are amniocentesis, CVS, cell-free fetal DNA reassurance, or the cell growth scan. Answer is reassurance as NT is 1.3 and alpha fetoprotein 1.06 and multiplies of median. Both the markers are within normal limits, suggesting a low risk for Down syndrome or other chromosomal abnormality. As her age is 37, with the Down syndrome risk is 1 is to 250. but normal NT and alpha fetoprotein reduce the risk significantly. So, baseline age risk alone is not an indication for invasive testing. Moving forward, a 35-year-old primary gravida attends the antenatal clinic for routine antenatal care at 13 weeks gestation. She has no significant past medical or family history. During counseling about her first trimester Down syndrome screening results, which indicates a mildly increased risk, she asked about the genetic basis of condition. She wants to know how Down syndrome is inherited and whether there is a risk of recurrence in future pregnancy. Here, the question is what is the mode of inheritance for Down syndrome? The options are autosomal recessive, dominant, or non-disjunction in meiosis, X-linked recessive, or mitochondrial inheritance. The correct answer is not disjunction in meiosis, as which lead to the gamete containing an extra chromosome copy of chromosome at 21. Most cases are most cases arise sporadically, and the extra chromosome is usually of the maternal origin. This event is random and not inherited in a classical Mendelian pattern. Rarely, Down syndrome can occur due to Robertsonian translocation or mosaicism, and in these cases, there will be the higher recurrence risk in future pregnancy. Other inheritance patterns are incorrect because in autosomal because why it is not autosomal recessive? Because Down syndrome is not caused by a gene mutation that follow recessive inheritance. Why it is not autosomal dominant? Because most cases of Down syndrome occur sporadic, not dominant. And why it is not X-linked recessive? Because both male and females are affected. It is not linked to the X chromosome. Like that, mitochondrial inherit. Down syndrome is a chromosomal disorder, not mitochondria. Moving forward, a healthy couple, both 30-year-old, attend the antenatal clinic before planning their second pregnancy. They previously had a child diagnosed with Down syndrome, trisomy 21. Both parents are chromosomally normal, and there is no family history of chromosomal disorders. The couple asked for the risk of having another child with Down syndrome. What is the approximate recurrence risk for this couple in their next pregnancy? 1 in 7, 1 in 25, 1 in 100, 1 in 1000, or 1 in 60? The answer is 1 in 100. As there is a recurrence risk after one affected child for couple with a previous child with trisomy 21 due to non-disjunction is approximately 1%, that is 1 in 100. So this risk is higher than the baseline population risk, which depend on the maternal age, but significantly lower than for the familial translocation. The recurrence risk is largely independent of paternal age if both parents are chromosomally normal. If a parent carries a Robertsonian translocation involving chromosome 21, the recurrence risk may be much higher, up to 10 to 15%, depending on which partner is the carrier. Next question. A 32-year-old woman present to antenatal clinic at 12 weeks gestation. She is pregnant with triplets. Confirmed on ultrasound to be trichorionic. The CRL of the largest fetus is measured at 67 mm. She requests information about screening for chromosomal abnormalities, including trisomy 21, 18, and 13. Which of the following is the most appropriate screening method in this scenario? So please, these are the options. The correct answer is maternal age and nuclear transparency. In trichorionic triplet pregnancy, the most reliable method for first trimester screening for trisomy 21, 18, and 13 is a combination of the maternal age and nuclear transparency measurement. Biochemical markers are unreliable in multiple pregnancy. So therefore, maternal serum screening is generally not recommended in triplet pregnancies. Now we'll start with the EMQs. Always take a look of the options that will provide you the mm, just how to proceed. Let's start with scenario. A pregnant patient present with a nuclear transparency measurement of 4 mm at 11 weeks gestation. If the fetus is affected by aneuploidy, she would terminate the pregnancy, but she would only undergo termination under 15 weeks gestation. So would like the test result before then. Which diagnostic test should be offered next? The correct answer is CVS because elevated nuchal translucency is associated with chromosomal abnormality and structural anomalies. The patient wants definitive result before 15 weeks to make the decision about termination. Hence, CVS provide early diagnostic tests from 11 week onward. Cell-free fetal DNA, again, it is a screening test. It's not a diagnostic. Amniocentesis should not be performed before 15 weeks as early sampling increases miscarriage risk and the risk of polyps. And while doing the CBS, the patient should be counseled about 2% risk of the mosaicism in CBS. Another scenario, a 37-year-old woman at 15 weeks gestation has a high risk result for trisomy 21 on second trimester screening. She is very anxious to decline invasive procedure due to fear of miscarriage following a previous pregnancy loss. She requests a non-invasive option even if it is not fully diagnostic, which is the most appropriate test. As she is seeing here, non-invasive test and which is more accurate. So the correct answer is non-invasive prenatal testing. As an IPT uses a cell-free fetal DNA in maternal blood, and the sensitivity and specificity of this test is more than 99%. CVS or amniocentesis are not of due to the patient preference to avoid invasive procedure, and this scenario highlights patient-centered care in the test selection. Moving forward, a 42-year-old Asian woman is seen at the booking clinic in her first pregnancy at 12 weeks gestation. She has undergone first trimester screening, which shows a low risk result for trisomy 21. Despite this, she is not reassured and wishes to have a definitive diagnostic test to know whether her unborn baby has any chromosomal abnormality, which is the most appropriate test to offer. So here we can offer amniocentesis. Why? Because both the CVS and amniocentesis are definitive diagnostic tests, but amniocentesis provide direct fetal cell, avoiding confined placental mosaicism, which can give the false positive result with SVS. CVS, and miscarriage risk with amniocentesis is slightly lower than the CVS. CVS is technically possible at 12 weeks, but amniocentesis is preferred when the patient is not under time pressure. So, the patient-centered care supports the test that maximize accuracy and minimize uncertainty. Next is EMQs. A 39-year-old patient undergoes non-invasive prenatal testing in a dichorionic twin pregnancy at 13 weeks gestation. The test reveals that the twin have dizygous and that one twin has a high chance of trisomy 21. Neither fetus has any structural abnormalities on detailed first trimester ultrasound scanning. What is the approximate risk of miscarriage associated with amniocentesis in this twin pregnancy? The answer is 1 in 100. Baseline miscarriage risk after amniocentesis in singleton pregnancy is less than 0.5%, that is less than 1 in 200. In twin pregnancy, both the sac must be sampled, so effectively doubling the procedure related risk. That's why the overall estimated miscarriage risk for amniocentesis in twin pregnancy is approximately 1 in 100. Another scenario, a 32-year-old woman experienced a miscarriage at 19 weeks gestation. The autopsy of the fetus reveals the following features: flattened facial profile, upslanting palpable features, small ears, brachydactyly, single palmar face, and duodenal atresia. Which of the following is the most likely genetic diagnosis for this fetus? It is the classic features of Down syndrome. The combination of the craniofacial features, limb abnormality, and duodenal atresia strongly support the 47XX plus 21. So correct answer is the Down syndrome. That is 47XX plus 21.
So let's begin with our another topic, that is abortion clauses. So before we go directly into the EMQs and the SPA, we'll talk about all the abortion clauses in quick. The clause A says that abortion is illegal in Great Britain, and it required two doctors to decide in the good faith that in relation to the particular pregnancy, one or more of the grounds specified in the Abortion Acts are made. Clause A, the continuation of the pregnancy would involve the risk to the life of the pregnant woman greater than if the pregnancy were terminated. Clause B, the termination is necessary to prevent the grave permanent injury to the physical or the mental health of the pregnant woman. Clause C, the pregnancy has not exceeded 24 weeks and the continuation of the pregnancy would involve risk greater than if the pregnancy were terminated or the injury of the physical or mental health of the pregnant woman. Clause D, the pregnancy had not exited 24 weeks and the continuation of the pregnancy would involve risk greater than if the pregnancy were terminated or the injury to the physical or the mental health of any existing children. So here there is a clause D, there is a mental health of any existing children, and clause C, the mental health of the pregnant women. Clause E, there is a substantial risk that if the child were born and it would suffer from such physical or the mental abnormality as a seriously handicapped such as the anencephaly baby, or the act also has permit the act also permits abortion to be performed in an emergency if a doctor is of opinion formed in good faith that termination is immediately necessary. Clause F and G both are the emergency clauses. F is to save the life of the pregnant women, and clause G to prevent the grave permanent injury to the physical or the mental health of the pregnant woman. So let's practice few EMQs. But before practicing EMQ, always ask yourself three things: that who is at risk, the women's life, the women's health, or the existing children or fetus, and how severe is the risk, whether it's a life-threatening or the risk of the permanent injury, non-permanent risk including the mental health, and then see whether it's an emergency or not. If it is emergency, think clause F and G. Not if it is not emergency, then clause A to E. So let's proceed. A 29-year-old woman present to the emergency department with profuse vaginal bleeding, severe lower abdominal pain, and hypotensive shock at 8 weeks gestation. On examination, the cervix is open and written product of conception. Despite initial resuscitation, she continues to deteriorate. Immediate uterine evacuation is required to save her life. So, most appropriate ground for termination of pregnancy is clause F, which is immediately necessary to save the life of the pregnant women. Here, a 21-year-old woman present to the emergency department at night with heavy vaginal bleeding and lower abdominal pain at 6 weeks gestation. A urine pregnancy test is positive. She is hemodynamically stable, but bleeding is ongoing. She is extremely distressed, crying continuously, and revealed that the pregnancy is result of rape. On the on-call consultant assessed the immediate uterine evacuation is required to prevent the grave and permanent injury to her mental health, and delay until daytime review would significantly worsen her condition. So, what is the most appropriate ground for termination of the pregnancy? Here, the answer clause G, because it is immediately necessary to prevent the grave permanent injury to the physical and mental health of the pregnant women.
Scenario: a 38-year-old woman, gravida 5 para 4, present at 9 weeks gestation, requiring termination, requesting termination. She reports that continuing the pregnancy would significantly impair her ability to care for her existing children. She has no medical or psychiatric illness, so it is clause D because the continuation poses a risk to the physical or mental health of the existing children or family, and it is valid up to 24 weeks. Moving forward, a 39-year-old woman with Marfan syndrome present at 11 weeks gestation, echocardiography show an aortic root diameter of 52 mm. Cardiology assessment concludes a high risk maternal death if pregnancy continues. This is clause A because it applies. Continuation of pregnancy would involve the risk to the life of the woman greater than if terminated. Aortic root more than 50 mm in Marfan syndrome carries a high risk of fatal aortic dissection. Another scenario, a detailed fetal anomaly scan at 20 plus 5 weeks gestation confirms the anencephaly. This is the lethal anomaly of clause F. Clause E. Sorry. Next scenario, a 24-year-old woman requests termination at 7 weeks gestation following failure of reliable contraception. She reports significantly psychological distress, but no evidence of permanent mental illness. It is clause C because that involves the risk of injury to the physical or mental health of the woman. Failed contraception causing psychological distress is valid. Next scenario, a 19-year-old woman present at 8 weeks gestation following rape. She is distressed but medically stable. Continuing the pregnancy is expected to cause significant deterioration in her mental health. This is again clause C. Next scenario, a routine anomaly scan at 21 weeks gestation show isolated bilateral talipus with no abnormality. The women request termination based solely on this finding as no clause is applicable because talipus is correctable and non-lethal. Next scenario, a 26-year-old woman requests termination at 10 weeks gestation solely because the fetus is female. She has no medical or psychological or social concern, so no clause applicable here because termination based on fetal sex preference does not meet any legal clause due to an emergency. We'll see few SPs from this topic. A 15-year-old girl presents to the clinic requesting an abortion. She is competent to make the decision but does not want her parents to know. She is anxious and requests confidentiality and asks whether she can consent to treatment on her own. This treatment is correct. Parental consent is required. She cannot be seen without her parents. She can give valid consent if competent or partner's agreement is required or confidentiality does not apply to minor. The correct answer is as per the special guidelines, she can give valid consent if competent. Confidentiality must be maintained and parental involvement is encouraged but not mandatory. Next, SPA. The 25-year-old woman undergoes a medical abortion at 8 weeks gestation. She is concerned about potential long-term effects and asks if abortions can cause infertility, miscarriage in future pregnancies, breast cancer, or mental health issues. Which statement is correct? These are the options. The correct answer is abortion rarely causes serious complication. In UK, abortion is extremely safe. Fertility usually return immediately. No proven link to breast cancer, miscarriage, or long-term mental health problem if decision is informed. Moving forward, a 22-year-old woman undergoes a medical abortion at 10 weeks. She is anxious about becoming pregnant again soon and requires advice on contraception. She wishes to start a method immediately and is inserted in an intrauterine device. What is the best practice regarding contraception after abortion? Delay contraception. Options are delay contraception until the next menstrual period. Only condom should be used. Offers counseling and method of choice before leaving the faculty. No contraception is needed and contraception is unsafe immediately after abortion. The option C is the correct answer. Offer counseling and method of choice before leaving because if you provide immediately the counseling and the contraceptive method that reduce the risk of the future unintended pregnancy. The last is here 24-year-old woman comes for counseling after discovering she is 11 weeks pregnant. She expresses concern about the safety of abortion at this stage. The clinician explained the timing and the safety profile of abortion procedure in the UK. Which statement is correct regarding the timing of abortion in England and Wales? Options are most abortion occur after 20 weeks, early abortion less than 30 weeks are most common, abortion are unsafe before 10 weeks, late abortion more than 24 weeks are most common, or timing has no effect on safety. The answer is early abortion less than 13 weeks, as 88% of abortion occur before 13 weeks. Early abortion is technically easier and safer. Late abortions are rare, usually for the fetal or the maternal indication. That's all about the today's topic. Thank you very much and all the best for your exam. Like clause G. Next in